Visibility, Stargardts Peer Meet, Professor Chen, 22nd of January 2022.
Thank you very much for the kind introduction, and thank you, Lynn, for inviting me to speak. And thank you all for coming today. And I realize it's a very hot day and it's not easy to get here. I'm going to talk briefly about how I came to be interested in Stargardt disease to start with, and then what we do in Lions Eye Institute. Yep. Okay. So I'm going to talk briefly about how I became interested in Stargardt disease. Then I'm going to list the kind of studies on a research project that we're doing at Lions Eye Institute, both clinical and laboratory. And finally, touch on the kind of treatment that have been explored for this condition. When I first came back 10 years ago, my main motivation was to set up a cell therapy program in WA because that was my PhD, to work on cell transplantation in retinal diseases. But I quickly realized that this was not feasible and we were not competitive enough in WA to be working on this. The kind of funding that we would have required was in the order of tens, if not hundreds of millions of dollars to be able to carry out such work. Just a comparison, the work I did in London on cell transplantation was only possible because we had 50 million pounds from Pfizer. So they gave us 50 million pounds just to spend whatever we need to. And as a result of that, the outcome was that 2 patients were treated, just 2. And then the funding was withdrawn. So there was no further funding from Pfizer on this project. Now we know what they're doing, Pfizer. So when I came back, we tried very hard to look at how we can grow cells, stem cells, especially from the cornea, how we can transplant them in rat eyes and to see whether these stem cells can rescue retina. And we did show that in a specific strain of mice, these stem cells were able to rescue the retina. And then I started to become interested in geographic atrophy because there was a gap in this condition. So geographic atrophy is what we typically know as dry AMD, so dry macular degeneration. And I was getting referrals of patients with dry AMD who clearly do not have dry AMD. So they were in their 30s or 40s. And for dry AMD to manifest, it typically occurs around late 80s. And so these are very unusual scenarios. So I got interested in these patients particularly. And in fact, what turned out to be that these people had Stargardt disease. And so they were misdiagnosed as age-related macular degeneration because of the late presentation. And so I got interested in that. And then fortunately, we had funding from a very generous donor family to look into inherited retinal disease. And that allowed us to employ a fellow who most of you have met. And there's different fellows every year who was able to help us to establish a registry and a natural history study into inherited retinal disease. And that's how we started to see all these patients, many of you and others, for us to understand the condition better. There's about 150 patients we've seen so far, a majority from Perth, but there were some who traveled from Victoria, New South Wales, and Queensland with Stargardt disease for us to see as well. Obviously, it's been difficult in the last couple of years. And we have monitored these patients, many of you here as well, for now almost 5 years and beyond, which really helped us to understand how the disease manifests and also importantly, how it progresses. Because ultimately, what we want to be able to achieve is a therapy that can slow down progression, first of all, before we can even reverse the damage. If we don't understand the progression of the disease, there's no hope of actually finding a drug that will slow it down. In the past, a lot of patients were not monitored or monitored in a way that was insufficient for us to design trials to test drugs. So for example, the typical way of monitoring Stargardt disease in the past was visual acuity. And that's the chart that you all read the first thing you come in. And that's probably the least useful test that we can do. But it's the most commonly used test in the past for monitoring disease. For 2 reasons. One, some diseases do not affect visual acuity because the disease occurs around the center of the retina. And secondly, In some situations, the visual acuity is so poor, and what's remaining is the peripheral vision, which cannot be accurately monitored by visual acuity. And so therefore, we have to look at other measures, for example, visual field tests, microperimetry, which most of you hate doing, and I'm sure I wouldn't want to be doing it all the time, which is a really useful way to monitor visual field. Then there's a whole lot of other pictures that we take, some of which have dim light and some are very bright light. And even though they are unpleasant, they are not harmful, but they do give us information that we cannot get otherwise just by looking at color photos. So visual acuity and color photographs were the typical way to monitor, but unfortunately they're completely useless in this day and world when we're looking at testing drugs. So that's the first part of the project that, first aspects of the disease we're looking at is clinical presentation, natural history, plus the genetics and how that fits in. The second aspect of it is looking at the mutations and how that affects the cells in the retina. In the past, diseases were modeled using animals. So for certain conditions, they will create an animal with a specific mutation and see how it progresses and manifests, and then perhaps test some drugs on these animals. That's fine if the disease is only due to one mutation, or two, or three. Maybe you can create three strains of mouse. But in Stargardt's disease, this gene called ABCA4 can be mutated in over 1,200 different ways. So we got a problem because Stargardt's disease is not a dominant condition; it's a recessive. So you got to have two mutations, one on each chromosome from each parent. And if you got say 1,000 different mutations on one chromosome, you could have possibly, and another 1,000 different mutations, you could possibly have another mutation on. So that's 1,000 times 1,000. You can see how many different combination permutation there are of this condition, right? So that's a million different diseases basically. So we can't possibly create that many different mouse models to test drugs. And so animal modeling really doesn't work, let alone large animals. The next best thing is really then look at the retinal cells from patients. But it really doesn't work either. We can't be taking out retinal cells from people with Stargardts because they need the retina to see. And we could, why don't you they pass and then take the retina? But the two issues, one is often the retina is so degenerated, there's not many cells left. And secondly, it's actually very difficult to get retinal tissue after death to grow them. So then the third way to do it is really to grow these retina cells with a specific mutation, different combination of mutation we see from the skin we take from patients. And some of you would have contributed to that. This is what's done in most major cities around the world. They'll have a program where they store the skin tissue, uh, examine what the mutation does to the gene, perhaps grow these cells into retina to see the effect on photoreceptor cells and the RPE cells, and then test drugs to see if they can reverse the damage in the DNA. We have so far one of the projects, it's a PhD project, a student called Dai Huang. So she's recently completed this project where around 60 skin cells were analyzed. We've got about 100 now, but at that time when she analyzed this, there were 60, and what she found was a great proportion of these patients' skin cell were expressing the gene in the skin cells. So she didn't have to grow them into the retina, which would have taken several other more PhD projects to complete. So just by looking at the skin cell, we were able to find the gene, which is surprising because this gene is not typically used, or this protein is not typically used in skin cells. So it's this ABCA4 gene is actually a gene that's only really used in the retinal cells to help vitamin A metabolism. And you wouldn't think that skin cells would need such a gene or protein to help with this vitamin A metabolism. But nevertheless, she was able to find splicing abnormalities, which is basically how the DNA and the RNA are processed in the cells in a good proportion of it. And therefore, we could then, in theory, use skin cells to screen for drugs. That can reverse these splicing abnormalities. So these are the two major projects that have been done at Lions. One is on the clinical aspect and one on the biology and disease mechanisms of the Stargardts using skin cells. Now going towards therapy, recently me and my fellow were looking at clinical trials listed on registries that look at treatment for Stargardts. And we found 21 trials listed, so current trials around the world. There were 16 in the American registry called the clinicaltrials.gov. You can look that up yourself. It's widely available. There was one in Australia, and it's the one that Lynn and I were working on, the BLIGHT study. And there were 4 others in European registry. So there are other registries we haven't looked into. So there's the Chinese registry, Japanese trials registry. One day, if I can read Japanese, I'll look into it, but not right now. And there are others in China which I haven't looked into it yet. So out of these 21 clinical trials, some are phase 1, some are phase 2, and some are phase 3. So the difference between phase 1, 2, and 3 trials are, number one, it's the primary endpoint. So first of all, what a trial is looking for initially for treatment of a drug is how safe or how dangerous it is. So that's phase 1. So phase 1 trial typically has only very few number of patients. So BLIGHT study that we're involved in is a phase 1 trial. So all patients gets the treatment, and the main outcome measures, or the main thing that they're concerned with, is safety. And so a lot of these trials then look at, what does it do to the eye? So look for inflammation, make sure the vision doesn't drop, make sure there's no abnormal liver function test, no abnormal kidney function test. Very basic, and nothing to do with the actual condition of the eye, although that's also of interest, of course. So there are, out of these 21 trials, there's ones on about 3 or 4 on stem cell transplantation, and a few others on molecules that are taken orally or injected into the eye. So these are the 3 main ways that Stargardt's disease are treated. And then there's phase 2, phase 3 trials. Phase 3 trials, on the other hand, are looking at efficacy. So once they've gone through phase 1 and 2 and proven to be safe and perhaps efficacious, phase 3 trials are randomized controlled trial where some patients will get placebo and some patients will get the actual drug, and generally involves several hundred patients and generally lasts over 2 years or longer. And so it's a much bigger undertaking, much more expensive to run, and hopefully lower risk. But there are many examples where phase 3 trial shows, unfortunately, the drug doesn't work. Then that's the end of it, the drug. And there are a couple of reasons why a phase 3 trial will fail. One is that the drug actually doesn't work, or it's toxic. They found a new side effect they haven't found before. Or secondly, which is unfortunate, is that the endpoint is chosen incorrectly. So the drug may actually work and safe, but the way they measured the effect of drug was incorrect. And that's a great shame, because then everybody misses out on the treatment just because the science behind how we measure disease progression hasn't been mature enough. And that's why there's so much importance right now placing on measuring natural history, because without understanding natural history properly and knowing exactly what to measure, we can stuff up the phase 3 trials like spectacularly, and then everybody misses out on the treatments. So you can see how this is all linked, going from natural history study all the way to phase 3 trials, and people working on all these aspects has to understand each other and actually design the trial properly. And it's not just the people who design the drug, testing the drugs, people who sees the patient, but also design the trial endpoints. And that's why, I think it's important that people like us, clinicians, are involved in all aspects of the studies, ranging from just, not just seeing the patient, but the patients themselves, understand their conditions, understand their history, stories, all the way around to developing the drugs, testing cells, and running the phase 3 trials. So that's a brief summary. I might talk about the PYC because that's something that some patients ask me about. So PYC came on board, I think it would have been 4 years ago. The reason why PYC came on board is because we had an invention to treat RP11. So RP11 is a form of retinitis pigmentosa, which is dominant. We actually have now over 10 families in Perth with this condition. And the initial motivation was because of there was an indigenous family with this condition that 5 generations affected with RP. And me and Sue Fletcher from Murdoch University got together, and I gave her a challenge because she's the world expert in splicing and developing drugs for splicing effect. And Sue and her team, the PhD students, came up with an idea, which we then developed further in our laboratory. Now, just by having an idea and a drug is not enough to get it into patients. So without the pharma companies' input, this drug would never help anyone. And the kind of help we need was not an NHMRC grant. So NHMRC is never going to be enough. It's not going to be $1 million or $2 million. It's going to be in the order of tens of millions of dollars to be able to get that drug into animal testing. And then approval by regulatory authority to do human testing. So that's where PYC comes in, because we didn't have tens of millions of dollars. Lionside doesn't have that. Murdoch University doesn't have that. There were interest from overseas in Boston, the companies there who's got hundreds of millions of dollars, and they were interested. But we chose PYC because they were local and they had the molecule which can carry this drug into cell. So that's been developed now to the point where the company is now confident this drug can work in human cells, cells taken from outpatients in WA. And the next stage is for them to then submit the data from the cell work, animal work, to FDA for approval. If they approve this, then we can then use the drug in human. That's when the hundreds of millions of dollars comes in, because running a human trial is not like a natural history study where we can just do in the clinic with minimal funding. They're usually in the order of hundreds of millions. So then PYC will then need to seek further funding for that to occur. Then they'll have to go through phase 1, phase 2, and phase 3 trials to see if the drug works. So currently they're looking at natural history studies. Again, it's what we're doing at the moment, but there are other places looking at natural history study of that disease, and really all across the board, all the 300 different inherited retinal diseases, now there are people looking at natural history studies. So that's the story, and that technology hopefully will be translatable to Stargardt disease one day. Currently, that's Stargardt disease is not one of the areas that the company is looking into, but the technology potentially could be applicable. So I shall end there. I'll be happy to take any questions anyone has. Any questions can be about Stargardts or anything else. Yes?
Natural history.
Okay, natural history is when disease is not interfered with by any treatment that we know can alter the progression of the condition. So for example, just observing what happened to the disease without intervention. Right, so one particular example will be, how does the atrophy size, or how fast does the atrophy size grow in Stargardt disease? If we can have a number, it could be 1 millimeter square per year. So that's the natural history of the condition. Without that number, we can't prove any treatment works, because you can say, oh, okay, I feel my eyes better, but that's not a proof. You got to say, once I take the drug, the growth rate has been reduced by 20%, so it's now 0.8 millimeter square per year. Or even better, it's now 0.5 millimeters square per year. Then you know that the natural history, which is 1 millimeter square per year, has been reduced by 50%. How do you do that? It's not linear. Very good point. So we don't know exactly. Yes, we can transform the data. So for example, area increase is not linear. So what we do with that is we square root it. So the area grows faster as it gets bigger. So it's not linear. So it's actually exponential. But once we square root it, we transform it into a radius. And we've plotted out all these numbers, and we find that radius grows linearly, but not the area. So there are mathematical ways around that. So the time frame, Jimmy get funding for stage development. Okay, good question. So phase 1 trials can For example, the B-Light study, 2 years for participants, but that will then depends on how many patients you recruit. So if it takes, say, 2 years to recruit these patients, 2 years to run it, that's 4 years already in phase 1. Phase 2 trials, generally, again, 2 years and more patients to recruit. It may take even longer to recruit. So you're looking at potentially another 4 or 5 years. Phase 3 trials, even bigger. You got 300 patients or 400 patients to recruit, but multiple sites, not just 1 or 2. And that could take easily 4 or 5 years. And so for a drug, for example, like the drug that we take these days for blood pressure, cholesterol, all those drugs, they generally take about 20 years to develop in the past. But these days, because of rare disease and there's ways, special pathways for rare diseases, some of these medicines are taking less than 15 years or as short as 10 years to get through, right from the beginning, from the first human study. So now we already know there are 21 studies in Stargardt disease that are already in human trials, some right at the beginning, and we know that's going to be a 10-year long road, and others phase 3 towards the end, but we don't know whether that's going to be positive or negative yet.
Groups that share information with each other, not like they're all trying to reinvent the wheel.
So the only information that's shared is what they're listed on the registry, right? So I can access that, you can access that, but they don't share the results of the study until they finish the study. But whilst they're carrying on conducting the study, that information is completely confidential because I guess it's company property. So these are run by pharma companies. And one will hope that what they learn from conducting the study will be shared in research publications that they publish as they go along, rather than withholding all the information until they get to the end.
Fred,
Yeah.
the cohort of people with Stargardt's disease in Western Australia, so you're working with about 150 at the moment.
Yeah.
Do you have any idea of how many more people might have the condition?
Yeah, the estimated prevalence of Stargardts, like out of say 10,000 people, they say there's one. Okay, so that's an estimated prevalence. So 2.5 million people, we will expect 250 people with it. So I think there'll be more because I don't think that 1 in 10,000 is accurate. I think there's more than that. Some are misdiagnosed as macular degeneration or as cone rod dystrophy or undifferentiated cone rod dystrophy. And so I suspect I'm seeing half of the people with Stargardts.
And how does that affect your study regime if you're trying to recruit a larger amount of people? Do you just go for a smaller cohort in that phase 3? Or do you still want the 200 to 300 people?
The more the better. The more the better, but realistically, a couple of limitations. One is our clinic. We can only see so many patients in our clinic. I wish I could have more fellows and more resources in line with our institute. And secondly, which is patients' preference, because some people don't want to be seen. That's fine, and I don't want to force them to come. And then there are those people who are not aware. Right, so they don't know they've got Stargardts, and their doctors never told them they got it, and never had genetic testing to confirm it. So these are the unknown unknowns, which we can't tap into. The more the better, just so we can understand the condition, or obviously recruit more patients. And that sort of places a limitation on Perth as a site to be conducting trials. Fortunately for Perth, we have the Australian IRD registry, who has been behind genotyping as many people as they can from local cohort. Whereas in Victoria and New South Wales, they have been genotyping, but they haven't had this longitudinal data or natural history study set up for as long as we have. So they're just picking up the speed. So there'll be more people with it picked up on East Coast. But I suspect we'll have the biggest cohort in Australia here in WA. Yeah. So carrier by definition won't have the disease. No, unless it's a misdiagnosis. So there are situations where Stargardt is dominant, called pseudo dominant, and the carriers, the parents carriers, may develop disease much later on because they have two mutations, but one is just extremely mild. And so they don't get a disease until their 40s or 50s, whilst their child has it in their teen years. Yeah.
As a child who had Stargardt, what is her possibility of then spreading it on to her children? She would have to have someone
Hmm.
like, yeah. If you had Stargardt, what are your chances of giving it to your children?
So all your children will receive one of the two
Okay.
mutation, and then the other mutation that child has is from the dad. And what's the chance of meeting somebody who carries one mutation in the Stargardt gene? Well, that's about 2 to 5% random population, and most of the mutation that these 2 to 5% will carry will be very mild. So in fact, meaning someone carrying a severe mutation is probably lower than that. And so if you do meet somebody who carries a mutation, then the chance of passing on the condition, whether mild or severe, will be 50%.
I'm so desperate. I do sever the Stargardt. They did tell me my 7% vision will stay the way it is, but which is not right. You can see light and shadows, and not much to be done. And I'm so desperate. I saw there's a tablet I found it online called Shell, the stem cell tablet. I'm start taking it. I'm on the second bottle. Dangerous what I'm doing is that I'm going to myself somehow or yes.
Yeah, so it is can be quite severe in some forms of Stargardts where the vision can be lost. 90% of vision can be lost later in life, and the treatment for the kind of treatment approach being considered cell transplantation to restore cells, and that is still quite far away. So, but there are clinical trials looking at stem cell transplantation, and then the second thing is trying to preserve which is exactly what you're trying to do with these tablets. Now, I'm not aware of the actual ingredients of the tablet you're taking. I'm very happy to look at it. Yeah, can I have a look, please? Okay, so it consists of vitamin B2, 6, 9, magnesium, vitamin A as well, and a couple of other things, lutein, zeaxanthin, zinc, and a few other things I don't know how to pronounce. So it looks like they're some kind of hibiscus flower extract. Okay, right. So I can go through all of those. So this is not cell therapy, obviously. This is nutritional supplements. Zinc is being used in age-related macular degeneration as a way of preventing disease progression, and it causes copper deficiency. So it really probably has no role in Stargardt disease. Lutein and zeaxanthin has a role in age-related macular degeneration, but we're not aware of that being effective in Stargardt disease. There's no trials done in that. So it may be effective, but we just don't know how much people need to take. And B2, 6, and 9, again, no trials done on those. Magnesium, no trials done. Vitamin A, I'd say, will be contraindicated in Stargardt disease. So it means that you shouldn't be taking any vitamin A supplement because vitamin A is metabolized into a toxic product in the eye in Stargardts. And so so anyone in Stargardts really, apart from taking the healthy diet, I wouldn't recommend taking vitamin A. The others I'm not aware of whether they're helpful or not, so I can't help you there. If you feel your visions benefit from this, right, it'll be difficult to explain scientifically, but there are many factors that can affect perception of vision. If you feel the vision stabilized from taking this treatment, Again, there may be other explanations apart from that, but without actually doing a trial, for example, 100 people taking this, 100 people taking placebo, we just never know whether this is truly making a difference. So I'm not saying it's bad, except perhaps the vitamin A part, but I just cannot comment on the benefits of taking this.
I am on my second bottle. I haven't yet.
Yeah, I mean, I can understand why you want to try anything. If I was in the same situation, I'll try anything too, and but not the vitamin A. Yeah. Yeah, again, it's there's antioxidants in that, and any kind of antioxidant perhaps in theory could be good. There is a trial looking at antioxidant, and that's the NACUITY study for Usher syndrome, but they don't use bilberry; they use N-acetylcysteine amide. So again, without a trial, I can't comment, but there's probably no harm. Yeah, so I'm not aware of bilberry being harmful in Stargardts.
Explain why.
There's a question online. Who is that? How do I do this? Who is asking a question? Okay. I don't hear it. Oh, there was a sound, but maybe it's not a question.
In regards to diet, is there anything we should be eating or drinking?
No. Everything in moderation is fine.
Before you talk about genetic mutation.
Yeah.
What kind of genetic testing are available, like generation?
Okay. So you're talking about family members who are not affected by the condition, all right? So there's two scenarios I can think of. So if you are, say, the offspring of somebody affected by it, and you want to know whether so one parent has the condition, and you want to know whether the other parent has the condition, because then that makes you 50-50 chance of developing the disease. There's two approach. One is to wait until something changes, and then you get your eyes examined, and if there's signs of Stargardt disease, then you undergo genetic testing as if you are a patient with Stargardt. If you do not have any signs in your eye, and you want to know what the chances are you developing it, it's possible to get a genetic test on yourself, or even on the father to see if they're a carrier. But obviously, you want to know yourself whether you're at risk. The result that comes back from that may show that, okay, you carry one of the two mutations from the mom, from the one of the parents, but none from the other. So that negative result is actually not very useful, because this number of mutation as mentioned, 1200, is what we know today. Last year or the year before, it would have been less than that. A few years ago, it would have been 500. And a few years ago, it would have been 600. And many years back ago, it would have been 2 or 3. So we're learning more and more about these mutations as we go along. So it's possible that we miss some mutation. Right, so a negative result in the setting of a normal eye examination is not helpful in excluding the condition. Obviously, it makes it less likely. So that's one. I guess the other situation would be, let's say, two couples having a child, and they want to see what's their chance their child can get Stargardts because they may have a family member who's got it. So there's a McKenzie mission that was still ongoing, where they test both couples, healthy couples, completely healthy, with or without family history of disease, to see if they carry one of selected genes that have a mutation in it. Now, Stargardt's gene was in one of those. They've actually taken Stargardt's gene out because it was too complicated to analyze. So I was helping with that analysis. People in the East Coast didn't know what to do with it. And so they were asking us to say, oh, does that look like a mutation or not? Because they're not sure. So I mentioned there's 1,200 mutations. So they're the variants we know that cause the disease. There'll be like tens of thousands of variations on the Stargardt's gene that we either believe they're benign or we don't know what they do to the gene. And so there comes the problem. So you found mutation in Stargardt's gene in both parents, or you found a variant, even worse, a variant in Stargardt gene in both parents. Maybe you don't know what to say to them because you don't know what the gene actually, what this variant actually do, the gene. And so therefore they're taken out. So it's not really routine anymore. There are people who still do it, but you have to go through GSWS or Genetic Services of WA to get genetic counseling and then testing. And I suspect they will say that because this is testing not for condition, it's for predictive uh, for family planning, therefore the cost will fall onto the patient themselves.
True. Is there any that the genetic testing is the way you determine whether someone has macular degeneration or Stargardts? Is that the only definitive?
So in Stargardts, you see some people can present with macular disease, just localized to the macula with late onset, and others can present with disease that grows from the macula to involve the entire retina. So that's called cone rod dystrophy. Looking at the mutation, we can sort of predict which one it could be. All right, so from genetic testing perspective, yeah, that is one way to predict whether someone is going to get a localized condition in the macula or a generalized condition that involves the entire retina as the disease progresses. But with most patients with Stargardts, they all start from the macula itself. So right at the beginning, looking at the eye, apart from knowing, if you know the age of onset, you can sort of predict. But if you just look at the eye, sometimes difficult to know. But genetic analysis result does help us.
Stargardt's the only retinal condition that has so many variants compared to like RP and
It is by far the one that has the most number of variants. So there are other inherited retinal diseases, but we're talking about over 300 different genes that causes retinal disease, and Stargardt's genes ABCA4 is just one of 300. Right, so in my cohort of 650 patients with inherited retinal disease, we've identified 40 conditions. But there should be probably 100 or more conditions. We just haven't tested everyone. And out of those 40, Stargardts by far the most common. ABCA4 is most common. The next most common are USH2A, so that's Usher syndrome or just RP, USH2A, and then PRPA31, so that's RP11, which is the drug that we designed to treat. RPGR is also quite common, but in terms of number of variations, these other genes may have a few hundred different mutations each, but really nowhere near 1,000 like Stargardts. There is another gene called, which is for cystic fibrosis, and that's probably got almost 2,000 mutations. So really these two, ABCA4 and the CFR gene, which is cystic fibrosis, is probably the most complicated genes to study. Yeah.
Great. Clearly, it's a marathon, not a sprint for you.
Yes.
And I was wondering, how do you stay passionate and in good work thing to do?
Talking to people like yourself here. I think it's patients who will keep me going because without that connection, it's difficult for anyone to understand the struggle Stargardt's patient face. Yeah, please.
Fred, in some time in the future, do you see the ability to take stem cells grown from the skin and put in the eye to restore vision?
I think that's possibly happening. We just don't know about it. So there are groups looking at that. We've actually tried growing skin cell into embryonic retina. We transplanted into a mouse eye. Unfortunately, it didn't survive. But this is from human to mouse. So really, there's a lot of steps there that we're skipping. There's immunosuppression that we need to give. Rejection is another issue. These cells are probably not mature enough to be integrating with the retina. They are not in the formal shape that you'll see in a normal retina. For example, embryonic retinal cells comes up in a ball. It's a cluster of cells. They're not in sheets. Photoreceptor cells in the retina are in sheets and two layers completely lined up. perfectly aligned. So there are people working on creating a substrate or a fabrication of the matrix that we see in the eye and put these cells in, so they grow exactly in an array that we'll see in the human retina. It's completely packed exactly like a honeycomb arrangement. Then put that into the retina and hope that it will integrate the same way as a normal retinal cells would. So that's all happening sort of behind the scene. There was in Japan a work on taking skin cell to grow RPE and then transplanting that back into patient with macular degeneration. But there was concern that they couldn't standardize the quality of each of these batches of RPE cell because they're basically making new drugs for each patient. And they couldn't standardize it. It's not a factory making the same drug for every patient. So cell therapy has that limitation that how do you standardize the quality of the cell when you're taking from every single patient individually? So it would have been far easier using embryonic stem cell where you know exactly where it came from and it's only one person's cell and use that for everybody.
Greg, can I ask another question?
Yeah.
The variation in age of onset that we have, that everybody here is quite significant. How does that affect how you do your lab work? Does it affect the cells once you actually replicated stem cells?
Yeah, it's a very good question. We don't know why the age of onset varies. So we looked at across different types of mutation. I certainly predict, if I know the mutation, say a baby has, the two mutations, we can sort of predict that. But we do see differences between siblings. So we have looked at over 20 sibling pairs where they have identical mutation, but the age of onset is different again. And so there's obviously factors related to environmental exposures. So there were male-male pairs or female-female pairs that are different, but male-female pairs are different again. And it's possible that females may manifest the disease earlier. Maybe it's hormonal reason. We don't know. So your other questions about
in the lab,
yeah.
replicating the cells, do they change once you've generated a new batch of cells? Do they deteriorate like what we?
Okay, so the actual mutation doesn't change because that's in the DNA. So DNA stays the same in theory, unless we do something to it in the process of making them into a stem cell. So there are methods to make skin into stem cells where the DNA is interfered with, and that can actually create new mutations. And that comes back to Lynn's point about generating a batch of cells from that patient. It might not be suitable. We might actually create tumor cells in that process. And then the next thing is about what about the rest of the cells? So let's say the DNA stays pretty much the same. Growing cells in the Petri dish is very different from growing cells in the uterus. There are variables that we can control, but others we can't. And also the skin cells that we get from the individual, let's say we got from a 20-year-old, what if we had taken from a patient when they're turned to 40 or when they're 60? So the skin cell age may have an impact on how we grow, how the outcome turns out. Right? So the younger person's skin cell might be better, might be easier for it to turn into a stem cell, and then from there it might grow into retina more easily than say an 80-year-old person with Stargardt disease, and her skin cell may have mutations already in from sun exposure or from toxins they've been exposed to through their whole life, which they may impact on how we grow the retina from that cell. Lot to consider. They're all very good questions. I wish my lab was here to listen to that. So they know how complicated it is. Ellen?
Should that drug become available, hopefully eventually, it will only be for people who are just starting to have deterioration.
Well, it depends how the drug was tested and in the population. Right? So, for example, the B-Light study we're testing in teenagers up to 18 years of age. And if that shows it's beneficial, then of course, then the drug will be approved for teenagers. But the company that developed this drug may be interested in testing adults as well who have later disease. And then if the trial shows that the drug is also useful in patient with later disease, then it will be then approved for patients with later disease. And so really your answer sort of relates to the kind of trials that's run and how the efficacy is determined. So there are drugs out there that we might not even know of, which may work, but they're not being tested or they're not being tested in the right way. So we don't know.
From signing up for the study, what else can we do to help?
Win lottery tickets.
Yes.
Sorry.
So I don't have hundreds of millions.
So there's a $50 million ticket there somewhere.
But how much is there other things we can do?
I think spreading the word, other people becoming aware of the condition, especially if you meet someone who might have Stargardts, getting them involved will be useful. And tell me, things that you're struggling with, and I can try and help and talk to others, like visibility, to invest into certain methods or training strategies to help. Yeah, I have to think about that a bit more, but definitely lots you can do.
Yeah, I'm sure there's plenty of people in the room. I have some time or some they can offer up.
Yeah. Yeah, Lee, you might have some idea.
With the group,
Yeah.
The online groups and things that we say that you can sort of share or connect and talk about.
I think it should probably more in the research rather than the studying sports side, because I think we all do that.
Yeah.
I'm asking more about.
I think try Fred.
Yeah. Take my skin and grow another one of me, if you can.
How young kind of person on your research program? The age when we start?
Right, so our ethics approval is to start monitoring from the age of 10, but obviously we've got patients younger than that who we've been monitoring as routine. The earliest diagnosis I've seen was, I think, 8 or 9, but there are reports of people developing condition at age 6 or 7, not under 5, never under 5. So if somebody's got onset of vision loss under 5, they don't have Stargardt disease. So their retina is completely normal when they're born. But yeah, it's very unusual to see under 7 or 8. Practically, most of kids at that age, will get flopped off as not listening in class, not respectful to the teachers. Seen a lot of optometrists with various glasses that never worked. And then eventually see somebody who say, oh, there's a retinal problem, and get an ERG done, electrophysiology done, say, yeah, okay, there's something not quite right, but we don't know what it is. And then a few years goes by, and then eventually they might find their way through the registry or see me, and then get diagnosed. Hopefully that will change. With what we do is try to educate ophthalmologists, optometrists to recognize these conditions early, to minimize the suffering to the family, but also understand the early stage of disease better, because we can then capture that in our study better.
Think like an ophthalmologist couldn't pick that up.
No, I think with education they will eventually be able to pick that up, but in our training, inherited disease is not featured, and so majority of ophthalmologists who establish actually haven't seen this condition or the early stage of the condition. They probably know when it's well established, 10 years down the track, but the very early stage are very hard to pick.
Has anyone online got any questions?
Still there? There are 3 people online.
To be able to talk. Are they muted?
Yeah, they're muted.
Oh, Michelle, help. They're muted from their end.
Yeah, they can unmute themselves if they want.
Oh, okay. I don't have them muted though, do I?
No.
Oh, good. All right. I certainly, I don't know if there's any more questions
can I thank Professor Chen for giving us that overview on research, current research, what's been going on in that space. Don't know whether it's okay for me to drop my mask or not, if that's any easier for everyone. And so you've taken us through quite a lot of technicality that I think we don't get an opportunity to hear. So it's been our pleasure to have you here at my home in Visibility, Vic Park, and have everyone in the same room or online. We've had some amazing questions, and I cannot underestimate the sheer value and relief I think people must feel when they finally get a diagnosis. That in itself, I'm hoping most people will agree, gives acknowledgement, gives explanation, gives a reality to what they're experiencing with their vision and some of their behaviours and difficulties. So Lynn has organised a lovely token of our appreciation to have you here on Saturday. And then
Visibility logo.